it's really, really a pleasure to introduce two people who are really a big part of the story that Joan and I have just shared with you. Dr. Chris Heery, who is on our medical advisory board. Chris, well, he might tell the story better than I, but Chris was an investigator at the National Cancer Institute when we met a number of years ago, and Chris was working on this vaccine that his group at the NCI had discovered that was targeting brachyury. Because of course, as Joan said, brachyury is important for other cancers as well, but they weren't including chordoma. And so having met Chris somewhat coincidentally, I stalked him afterwards, and through a series of conversations, Chris not only got interested, but really took on the cause of chordoma to a greater extent than I ever could have hoped or imagined, and has become truly an integral member of the chordoma research community, one of our most trusted and important advisors, and someone who's really truly become a friend. And Chris, I just can't thank you enough for your dedication and what you've done for this field. So someone was asking yesterday about chordoma immunotherapy. I think it's actually safe to say there is no one in the world who knows more about chordoma immunotherapy than Chris Heery. So we're really, really grateful to have Chris here today. And it's also really special that we're joined by someone who I think many of you know, really a founding member of this community and the impetus behind this the community conference series, Dr. Bill Dorland, and I'll let Bill introduce himself and tell his story. But it's really actually thanks to Bill's effort, encouragement, and ideas that this conference even came about back in 2008. And some of you, many of you in this room will remember the leadership that Bill took to get the first conference off the ground. And so I don't want to steal their thunder, because they're going to tell an incredible story of how the two of them have come together and the incredible results that have emerged, and how that perhaps provides examples for what's possible for others who may be facing a recurrent or advanced chordoma. So, Bill, Chris.
Thank you, Josh, for that introduction. I think it's always funny to hear it from the other side, because I actually chased Josh down too. So I had seen his story. I went to Duke undergrad also, and I somehow, yeah, well, I can say that because we won last night. So, and I somehow had seen this story about this. He was a kid who was creating an infrastructure to treat an ultra-rare cancer. And I was like, this is amazing. And I also thought, I remember being his age, and there was no way I could have done anything like what Josh had been doing up to that point. And I was invited sort of accidentally. My boss was invited and he couldn't go, so I got to go to this meeting of this group that is supposed to advise the head of the NIH, the NCI. And I was asked to give an overview of cancer immunotherapy, and I was standing there talking, and brachyury was the example I used, and Josh asked a question, and I thought, that's that kid. And, and so anyway, we got to go get coffee and talk for a while, and within, I think, 2 or 3 months, I had come to the first of these conferences, so this was in 2013, I think, that I got to attend. And only about 3 months after that, we had finally reached the stage of one of our clinical trials where we could add patients with chordoma to the trial. And that trial is the trial that Bill eventually enrolled on and led to some what we hope are really important discoveries that hopefully will lead to more treatment options for patients with chordoma. One other thing I'll just mention, though, is that when Josh first approached me, I said, you know, there's only 300 patients a year. We'll never get any patients enrolled. And he's like, I think we'll be able to help you out. So we had this threshold event we had to cross, and I said, okay, we've crossed it. Can you put out something on the website, a press release? And he did. And that day, in the following 5 days, I had 30 patients with chordoma call our office. And my research nurse was like, what is this? I can't deal with this. I don't want to deal with this. And so we ended up enrolling 11 patients on a phase 1 trial, all chordoma patients, 11 patients in 6 weeks, and we could have done it in 1 week, but the 6 weeks was only because my research nurse was yelling at me, right? I mean, that was the only reason. So I think it's a real testament to the community that's been built that that's possible. I think it also shows us that there are patients willing to mobilize to be a part of something bigger, and that has a lot to do with Josh and the organization and the foundation that's been built, but it also has to do with people really knowing that they need to be a part of something bigger if they want to help themselves, and I think that's a completely valid reason to do anything. And what we're seeing right now is sort of the nexus of a lot of great science and the infrastructure that's been built around that, and the willingness and ability for companies to invest in that because they see the same thing that I've seen. And I've told this story to a lot of drug companies over the years, that the patients will show up. The other thing that we know now is that we need enough sites around the country that are enrolling the same trials, or in Europe, or both, so that every patient has access to the trials. And that is a big hurdle. It's a big investment, and it takes a lot of time and thought to get to that point. So I'm going to let Bill maybe give his version of the story of how we met and some other things.
Well, I'll say just a few words because in addition to tag teaming up here and trying to make sure you're awake, we have some material to go through, which is about how you make the decision about what to do next if you have a recurrence, and what are the options and how do they compare, and how do you navigate the materials that are in your book. So we're going to do that too. My background, why did I get picked? I had to write it down because I've had several versions of this thing. So I was diagnosed in 2004 and had a recurrence more or less immediately. And so I've had treatments at Johns Hopkins, Sloan Kettering, Mass General, and NIH. And in the course of that, what I had to write down was the trials I've been in. So the proton treatment formally had some sort of trialness to it, but that's not a trial. I did this SRS, which is image-guided stereotactic radiosurgery. I've had oncolytic bacteria. Sounds great. Didn't work for me, but it was pretty exciting. If you know, there's a famous person in cancer generally named Bert Fogelstein. He's one of the leaders of the field, and he personally injected me with this stuff, which was very exciting for me. No, it really is. He's a superstar. It was great. I've had the brachyury yeast that we were just talking about in this GI 6130 with radiation. And then anti-PD-L1 and TGF-beta trap. So I had to write those things down because I couldn't remember them all. So many of the things, Chris is going to take the lead here in a second and start talking to you about the options that you have and how to think about them. And part of my role is going to be to follow him and to say, give you a patient's perspective on how they work, because not how they work for you, not how they work medically, but how does it feel to go through them as a patient, and how it works at a sort of mechanistic level for showing up and throwing up or whatever it is that happens. So let's let the doctor take over, and I'll make funny pictures behind his head.
All right. You never never threw up on any of
No,
my trials,
no,
did you?
no.
Not that I know of. Not from the medicine end,
No,
right?
no.
Yeah. All right, so I do like the way that Bill has been reduced to, his PhD has been removed. I didn't add that, I'm sorry, Bill.
Yeah.
Sorry. Bill is too modest, he's a brilliant physicist. All right, so, is this one not working for today?
Here, let me do it. I know how to do this.
Oh, it went. Okay, so I'm going to go over just a summary of a lot of work that was done by, again, by the foundation to organize a large group of physicians who have experience across multiple modalities of treatment paradigms. And what I mean by that is, as you all probably know, it takes a lot of different specialties to treat chordoma. So you need a radiation oncologist, but you need one who understands the particular part of the body where your chordoma is found. You need a surgeon, but you need one who's expert in navigating the specific part of the body where your chordoma is found. And then you need a medical oncologist, and we're not that smart about anatomy, so we do clinical trials, we understand drugs, but what the medical oncologist typically does is helps to oversee the various interactions of the doctor. So it's important to bring all of those specialties, and then of course we need the pathologists who review those slides and tell us exactly what is going on under the microscope, and we need radiologists who look at the pictures and tell us where the shadow ends and the tumor begins, right? So it's a lot of different people, and you might wonder when you walk into your clinic, why are there so many people weighing in on what's going on with me? It's because none of us can possibly do each of the things that all the other people can do alone, and we need the input of the others. There's one other group that does play a role in treating chordoma sometimes, especially in recurrent setting, and that's interventional radiologists. It's another group of people you might meet at some point. And so you can see that it's a big team effort. It takes a lot of coordination to make these things work. All right. Did it work?
Yeah.
All right, cool. But see, what's going on? All right. So this meeting, which was organized by the foundation and occurred in November 2015, the results of this consensus discussion were published in February 2017 in a medical journal called the Annals of Oncology. And the purpose was we kind of knew going into that discussion that it's very difficult to cure any patient with an advanced solid tumor. And when I say solid tumors, I mean not lymphomas, leukemias. We can cure those even when they're very advanced sometimes. But with advanced solid tumors, it's very difficult to cure. So the guidelines are really around what do we do to maximize the treatment benefit in terms of what patients really care about, quality of life, and duration of life, okay? So those are the two main goals of making these guidelines. And that's true of any cancer, but it's unique to have a cancer like chordoma where there is a relatively low number of patients and get 60 doctors all in the same room to talk and argue about it. So it's an impressive feat for the foundation. So what is, just some definitions here, what is a local recurrence? That means that where the tumor was taken out, basically it's grown back in the same place. And a regional recurrence means that you are somewhere in that vicinity, but not necessarily in the original tumor bed, okay? So why do we see regional recurrences? We know that chordoma is kind of a sneaky tumor. It kind of infiltrates, and we don't really know how that works exactly. We believe it has something to do with brachyury. What we've hinted at a couple times just in this session is that brachyury has the capacity to change cells into the type of cells that are very good at moving around through other tissues. We find that in other solid cancers like lung cancer, breast cancer, prostate cancer, colon cancer. But since every cell in chordoma, for the most part, has high expression of brachyury, they all act this way. And so we can see a very defined tumor mass, and then if you look 2 centimeters away, there was normal tissue in between, there's another little pocket of chordoma sometimes, okay? So that's why regional occurrences can happen despite excellent surgeries with clear margins. So how do we diagnose a recurrence? Typically, there will be follow-up scans, right? After you've had your definitive therapy, after your surgery to remove all of the cancer or radiation, you'll have follow-up scans. And usually, the recurrences are close to where the original chordoma was. Occasionally, they're far away in another part of the body. That's called a metastasis. And in order to see that, you have to do imaging, not just of that local area, but of the whole body. So these were the recommendations about what is done when you're looking for evidence of a recurrence. Obviously, an MRI scan with contrast was kind of the top line of what needs to be done. And then a CT scan, and if you, I'm sure some of you know the difference and understand the difference, but really the main difference for you is that one is really annoying and one takes about 10 seconds, right? Right?
Yep.
So,
So you learn to sleep through it.
right, yeah. But so an MRI is the one that's pretty annoying, but the pictures are generated by using a high-powered magnet, getting the ions in your cells to line up, the water molecules basically to line up in one direction. And then as you turn the magnet off, they start to spin at different speeds. They start changing directions in different speeds, and then you know which tissue is which. A CT scan just shoots radiation through your body and catches it on the other side and tells the difference in density of the tissues. And so CT scans we can do them literally in about 10 seconds, almost your whole body. But an MRI, you can't. The other thing is that if you're going to be doing all these things and you're not sure what you see on the picture, a biopsy is recommended. Not absolutely necessary if you're pretty confident of what it is, but along with these guidelines, there had been some discussion just during this meeting of the value of trying to get more biopsies. I would highly recommend that you talk about the risk and benefit of biopsy directly with your doctor before you even consider a biopsy. There is a concern that when you put a needle into a chordoma, as you pull it back out, some of the cells of the chordoma can get on the track and cause a local or a regional recurrence like that. There are some techniques that can reduce that risk, but just to be aware of it. So the most important thing I think that we all agreed is that once you know that there is a recurrence, find a team that knows what they're doing. Find somebody who has all of those kinds of doctors that we talked about, and make sure you have access to someone who can help you guide yourself through it and refer back to this, the nice pamphlet that's in your bags. I would highly recommend anybody in this situation, please reach out to Shannon and her team and try to get at least a couple of opinions. I told every patient that saw me, please go see at least one other doctor, maybe two, because I want them to disagree with me so we can at least talk about the things that we have disagreement on, and you can make the decision yourself, because there isn't a right and wrong answer for most of this stuff. There's guidelines. So when we are trying to determine what to do next, we need to know the extent of the disease. So those scans that I mentioned, now it becomes important once you've found the recurrence to definitely do a scan of the whole body and make sure that we're not trying to treat one thing when there's actually 6 things to deal with, okay? When it comes to now what those treatment options are, it's gonna get a little murky here, but try to stick with me. They're influenced by what you've had before, okay? So if you have a local recurrence or even a regional recurrence, the amount of radiation you had before is going to influence whether you can have more radiation and how much radiation and to which parts of that recurrence. So it's really important. If you ask me, can I get radiation to this? I say, I don't know, right? I need the radiation oncologist to look at how they treated you before and how much radiation you got to this area, and then they can tell me what else they can fit into that picture. I do not understand how they do all of that planning and things. That's not my job. it's their job. So I would often get that question as the medical oncologist, and I know it sometimes seems like you're getting the runaround, like, why can't you just tell me the answer? Well, I don't know, and I don't know how to tell you. So it's really important to get all the right people talking to you, and ideally at the same time. The treatment options are going to vary considerably by the location, and it's important to consider all those side effects and have good conversations. I would also say try not to rush into decisions as much as possible. All right, so what are the treatment options that we have in addition to radiation? There's debulking surgery, which I would say is generally reserved for trying to reduce the symptoms, right? So if something's pushing on something and causing pain, then surgery might make sense to improve it. Again, if surgery could possibly get wide margins and can result in cure, that's a very high consideration, although that's not typically the case in these situations. Now, I mentioned interventional radiology, and you might say, what is that? Those are people that use the images that they get when they do a CT scan or an MRI, and then they can guide a needle or something directly to where that tumor is, and that's what are called ablation therapies. They can stick something in and either freeze it or microwave it or heat it up or inject radioactive beads. There's a lot of different things that can be done. And they're cool opportunities sometimes, but they're not perfect for everybody, so it's important to talk through those scenarios. And then clinical trials. I'm obviously a little biased here, but I think clinical trials, especially in a disease like chordoma, should be, when possible, one of the top choices, right? So if you are thinking through the treatment options and you said, well, my treatment option is going to be low-dose radiation. I know it's going to be low-dose radiation. Check to see if there's a clinical trial that has low-dose radiation in it before you just do the low-dose radiation, right? You don't have to do the trial, but at least find out about it. And you might find that you get access to something that you otherwise could not have had access to because it's not approved yet or whatever. And this is the scenario that I hope Bill mentions. He was on a clinical trial. He had had radiation that probably wasn't sufficient to control his disease. And then he went on a clinical trial and his tumor shrunk. And so we don't know for sure whether it was the radiation or whether it was the therapy on the clinical trial or the combination of the two. But it at least creates some hypotheses that maybe we can build off of. So the other option, and this is a very real option, is to watch and wait. And I know that that can sound really scary, but sometimes being patient and looking to see how things are going to evolve is the best strategy. And that takes some very thoughtful discussion, but I would tell you, don't be shocked or scared or surprised if that's the thing that somebody recommends to you. Again, get a second opinion, right? But just by waiting a month or two, you might find out, maybe I don't need to jump into action right now. And that's an okay thing. For advanced disease, and this is disease that is now sort of outside, can't be outside of a localized area, definitely can't be treated with high-dose radiation, and includes metastatic disease. Now we're really talking about trying to use systemic therapies, but there is a role for local therapy when a single spot, a single tumor is the one causing the biggest problem. So for instance, if you have metastatic disease and there's one in your lung and you have a recurrent cough or it's causing pneumonia behind that thing because it's pushing on the airway, it might make sense to either surgically remove that or do an ablation of that lesion. Sometimes we can even open those things up with a stent. There's a lot of different things that can be done, but most of the time it's about making sure that we're controlling symptoms related to metastatic disease. Most of the patients I treated at NCI had advanced metastatic disease, and very rarely were the symptoms that patients were experiencing from the metastatic sites. Most of them were from the original tumor sites. So we might balance our treatment based on, well, I want to take care of the other stuff so it doesn't get out of control as much as possible, but I really need to focus on the thing that's causing pain, limitation of function, whatever it might be, okay? So that's always a discussion to have. And again, clinical trials in this setting make a lot of sense and are really something we should encourage encourage each other to be a part of and seek out. And again, Shannon and her team can help you find what those are. And I encourage everyone to look at the website and look at the list of trials. It is growing all the time. that are relevant for chordoma patients and also that are specific for chordoma patients. All right, so Bill's going to take over from here about how you actually do this.
Is that chair? Yep. So a couple of things. I was taking notes there at the end. The wait and see part, when I started out, I thought wait and see was terrible and it was hard to bear, and there was a lot of discussion about scanxiety, or however you pronounce that. I've gotten really good at wait and see, and it's not always the best thing to do. You have to talk with your medical team, but it really works, and the way to remember it is, it's right there in the name, be patient. You are a patient. It takes time for these things to really declare and to become clear what the right strategy is, and so I wanted to echo that. The other thing is, before I start talking a little from the slides, I wanted to say that I forgot to say thank you to Chris and to Dr. Kokaslin and to, I think at this point I've had 15 different medical doctors, most of whom have been at this meeting, and so these people save your lives. Also the friends here in the foundation and the colleagues that encourage you to chase down all the possible answers and select the best one, and these are people that will save your life many times over, so thank you. Thank you to everybody. Okay, so, you know, when those of us who've been around for 10 or 15 years were first diagnosed, there were no easy answers online. Mostly you Googled chordoma and gasped in horror because it said terrible things. And now there is more, and there is better information available. And in particular, the materials in your book and the materials online, if you find yourself wanting to look at the latest and greatest and not just what's been printed up, is fabulous. So the Chordoma Foundation makes resources available, including a doctor directory. There are many, many fine doctors, many, many fine oncologists. They don't all have a lot of experience with treating chordomas, and so it's helpful and important to use the materials that are available to you through the foundation to find the doctors who have that experience. If you choose to go with someone else as part of your therapy, that's up to you, and that's fine, but there's certainly a lot to be gained from talking to people who have a lot of experience with the disease and can help you think through the choices that you have, even if you choose to do something that isn't the first thing that came up. There are, the materials include, you know, finders. It's challenging because our doctors are super accomplished, and so they're moving around all the time. And you may think you may hear from someone that Dr. So-and-so is at such and such a place, and typically by the time you've heard it, they're already somewhere else. And that's okay. It's all up to date with the foundation, and we can help you find all those people who have that experience, and so use these materials. The trials part is extremely hard to manage. If you, and many of you probably already have, if you start Googling trials and you use the word chordoma, you get one kind of list. There are materials online that have a great deal of information really for people with a medical background to dig through, and you know, I have dealt with the disease for a long time, and I'm not afraid to dig into technical information, and it's entirely impossible. You can't possibly understand all that stuff from a patient perspective, at least I couldn't. And so at the website, there's a list of clinical trials, and as Chris said, they're not all chordoma restricted or chordoma specific. There are also trials like the one that I joined with Chris, which were open to chordoma patients, but were established for other cancers and other situations. So all of that information is maintained at the foundation website and is up to date, and so it's a really great place to look. In addition, you get told many, many things. I tell many people when I come to these meetings every year or two that it's, as Chris said, it's very, very important to seek second opinions, third opinions. Only in the very first instance when I went to Johns Hopkins and after 4 years of having no knowledge of what was causing my symptoms, within 15 minutes of meeting my surgeon-to-be, I had a diagnosis and a plan and an exact explanation of what would happen when and how it would all go. And I went to Sloan Kettering for a second opinion with Dr. Boland and didn't tell him anything, just said, here's my information. And he gave me exactly the same story. And so that was fabulous. I knew what to do then. I had a clear idea. After that time, every time I spoke to a different doctor, I got a different story with different words and different opportunities and different possibilities. And it's very hard to keep track of all that stuff because it rapidly devolves into trade name chemicals that, you know, even the same chemical has a different name when you're talking to different doctors. So it's very tricky to keep track of it. And the resources that you can see here, there's a sort of a translation table so that you can make sense of what you're being told, and you can use that to make sense of questions that you need to ask when you're talking to your healthcare providers. So I think this is really very helpful. When we say systemic therapy, and I didn't correct him on any of his physics misinformation that he was telling you about, but feel free to correct me on these. Systemic is largely things what you and I might call, the patient community might call chemotherapies or immunotherapies, things where it's not targeting directly a single point in the body, but rather you're getting medicines that could affect chordomas or cells that have gotten away or are running around in your body, no matter where they might be found. So that's how I think of systemic therapy. You do okay? Yeah. So that kind of information I had to more or less figure out on my own back in the day, and now it's collated and brought together, and then there's people online at the website to help you understand it. And speaking of people on the website online helping you to understand it, I assume everyone here has already met Shannon. Shannon, you want to stand just in case? There she is. I think I heard, and probably you heard it too, but I'll repeat it, that Shannon's already in the last year, maybe two, I don't know the precise number, has helped 650 people. This is incredible. This is fabulous. And so, you know, be number 651 if you haven't already done it. The services are described, and, you know, Shannon's here, so rather than having me characterize it and talk about it, I'm just going to say, no matter whether you think you need it now, this is a good time to shake someone's hand and talk to them in person and sort of establish a little bit of contact so that if you do need to speak to her down the road, it likely would be largely over the internet, at least in the beginning, and so it's good to have established some sort of rapport. The last topic is something I spoke about 2 years ago at this meeting, and it's something that's near and dear to my heart. My next door neighbor, we just moved actually, so for 18 years my next door neighbor was a doctor. He's still a doctor. We moved. It's complicated. Yeah, sorry. So at a certain point, things were getting very tricky for me. I had run out of all the standard care options, and I had talked to lots of different institutions and doctors, and nobody had a real clear way forward. And so in 2015, my neighbor and one of my best friends recommended that I check out palliative care as an option, not because I needed it at that moment, but because when I did need it, it would have been better to have already established it and talked about it. And this has been one of the best decisions I made throughout the whole 14 years. If you sign up for palliative care, you are preparing yourself in case you need it for more options that include pain management, management of symptoms which are not fundamentally related to your cancer or related to your situation. For example, 3-4 years ago, I walked fine, hiked, jogged, did all those kinds of things. And changes happen as you go through a lot of different things. And your palliative care team is there to help you with the whole range and how it all fits together, and not just the precise specialty of the person that you're talking to or the team that you're working with. They also typically employ people who are social workers or psychologists and therapeutic help. If you know, a lot of what we have, it doesn't get called it, but it's PTSD. You know, you're going to go through a lot over the years, and if you're not lucky. And I know that so many years in, when I hear a siren, I always first think, oh, is that for me? Are they coming to pick me up? You know, it's how you end up thinking about the world. So these kinds of resources that happen through palliative care centers can be very helpful. And also planning ahead if you might need to go or if you wish to go into hospice at a certain point in your treatment, having talked about that before you're in a situation where it's a much more difficult conversation to have is something you can do through a palliative care team. So I met an oncologist and a team through the palliative care system that I joined. And despite the fact that after Chris's miracle and miracle intervention that I was in a wheelchair rolling around, you know, unable to walk with a broken hip and all that stuff. And then it got better. Yay, immunotherapy. That's very good. At the same time, I wasn't kicked out of the palliative care center just because things had gotten better. And that's actually my GP, really. I go to them for everything except the precise things having to do with chordomas. And it's good to have a team that is used to dealing with very complicated situations and unafraid to try to put two and two together and understand why one symptom is affecting another thing. So it's really good. I think these are my last few words. In addition, you can see there on the screen that there will be, for each of the things that I just described, there will be on a palliative care team, at least in a larger medical center, which you should be already talking to because you have a rare disease. There will be specialists at those palliative care centers who have all of those different things. And so you get not only a lead person who can help you with the management of the disease, but also access to specialists. Okay, so in your packets, there is a book. This is a really major step forward to have this kind of information and to have had it published in the medical literature. One of the major accomplishments for patients in the here and now that happened early in the days of the Chordoma Foundation was the establishment of care guidelines that were published. And that immediately led us for first diagnosis. And that let us as patients talk to our insurance companies without the specter of having everything declared experimental when we were having exactly the same kind of treatments that we were told at many different centers that we should have. Now we have this kind of published information about recurrences and how to deal with that, and it's just a fabulous big step forward, and it takes a huge amount of time on the side of the medical community practitioners to take part and go through all the things and hash out what they all agree on without ending up saying nothing. In fact, very significant things have been said and published, and this will help all of us as you go forward. If you don't have a recurrence, it will help you feel better that if it ever did happen, that you'll be ready for it. And if you do have a recurrence, then you have some really solid information there. And so that's in your booklet. Now, we're probably a little over time, but I think we inherited being past time. So I'm going to stop talking, but we were supposed to let you ask us some questions. And so maybe we'll do that for at least a couple of minutes. We usually have a comedy routine we do, but we're trying to be serious here. So, anybody have any questions? Also, we'll be around, not for the duration necessarily, but for the next few hours. So, if anybody wants to talk about these things in private, we can do that. Yes.
You talked about the importance of finding experts who really like being a team effort.
Yep.
Oh, thanks. How difficult have you found it to be to have experts who are currently at different hospitals, universities,
right,
coordinate together? Like, are they willing, and how does that work?
So, in nearly every instance, despite the fact that I live with within a few miles of Johns Hopkins, which is, one of the premier institutions in the world, I found it necessary to try out travel and to work with doctors at different institutions. And it's not always perfect, but the key is when you go in for a test, particularly some sort of scan or interventional radiology where there's information that is gained, walk out with as much information in your hand as you can, because they're not allowed to just send it to each other easily without a lot of paperwork being signed, but you can hand your medical information to anyone you want. So my distinct impression over the years is that I've never found two doctors who didn't want to talk to each other and work together on my behalf to come up with the best outcome. But it's often hard in the beginning and often over a period of time for that to happen. And so I've learned how to carry everything that's needed or is likely to be needed and just hand it over to them as soon as I can.
Thank you.
Yes.
Just to finish on hers, I take a thumb drive with all of my records. I mean, everything is on the thumb drive, so it makes it really easy rather than what I used to have to do is send multiple big envelopes to doctors with everything in it. But if I'm on currently the DART clinical trial, and for those of us who say we're on a clinical trial, it's maybe for solid tumor or whatever, if we find out eventually that it's not working, are we still candidates for one of the Chordoma specialized trials?
Yeah, so every clinical trial has what are called inclusion and exclusion criteria, and those criteria determine whether you're eligible or not. Most of the time, when you're treating a rare tumor, you will make extra special allowances to let as many patients on as you possibly can. So if you've been on a clinical trial, it does not necessarily exclude you from another clinical trial in any way. And in most cases, we couldn't even do clinical trials if we tried to do that because we'd run out of patients to enroll. It is a select group of patients that typically seek out clinical trials and are willing to travel for them. And so on the trials, for instance, the trial that Bill was on, most of the patients, that was their third or fourth, and went on to 2 or 3 more in our clinic alone. So that happens quite frequently.
So if you have a recurring lesion that comes up and it's in the same area as the original tumor, can that be taken and sent to be typed, gene typed?
Right, so maybe this would be a good question. Is Patty in here? So the Chordoma Foundation does have a tissue bank that can help organize the tissue that gets taken so that it can go to more of a systematic approach. But an individual approach, absolutely, there are commercially available tests where that can be done. I would only caution that as of today, there is no direct link between anything you would find from those tests and a treatment that is known to work, because we don't have any treatments that are known to work, right? So what I would suggest is if you'd like to do that, you will get a report, and that report will give you certain potential targets, and then those become targets that you might want to seek a clinical trial on. And then those clinical trials, you should make sure that they're aware, the investigators are aware that I sought this clinical trial because I have this change in my tumor, and that will also help them inform what they're trying to achieve. So that's, to me, the main, the really good thing about this ability to do genome sequencing and RNA-seq on a broad platform. But the downside is that there's a lot of false hope and hype around those things. So I encourage people to be realistic about what the information they're getting back is.
Okay.
That's it.
All right. Thank you.
Thank you.